Thank you. I'm really excited to be giving this talk today. I want to start off my presentation with kind of two acknowledgements. So one acknowledgement is that I'm certainly not an expert in this field. I'm not an expert in nephrology, hope to be one, and I'm not an expert in addiction medicine. I also hope to be one. The second acknowledgement is I present a kind of very optimistic path forward. The reality is that we have some of the sickest patients with addiction within our kind of department. And it can often be very hard to see through what these patients are going through to an optimistic future. And I just want to acknowledge that we kind of all, I just want to kind of acknowledge our experience as we take care of these patients. I want to start by talking about the epidemiology of kind of opioid use in Seattle. And looking since 2020, the landscape of substance use in Seattle has completely changed. So what we were seeing is, a moderate amount of heroin use up until 2020, when things changed and people started to use a lot more fentanyl and methamphetamine. I'll only be talking about opioids today, but fentanyl is extremely potent, and kind of the rise of its use has led to a lot more overdoses and a lot sicker patients with addiction. So looking at the cumulative overdoses, it seems to have peaked in 2023 with about 8,000 cases per year of opioid overdose. And that's reflected into opioid overdose deaths. So fatal overdoses in 2023 were kind of peaking around 30 a week. That's a massive amount of mortality for our community. And this crisis really lives in our department. We have some of the heroin use, and as you all have taught me, has been associated with AA amyloidosis, causing renal failure in a large number of our patients. I believe it was about 40 patients in Harborview in 2022 had AA amyloidosis, and that number has only increased. I know I've personally had the misfortune of diagnosing a number of patients with new ESKD attributed to presumed AA amyloid. I also had the experience of going through my incomplete notes and deleting them. And through my time at Harborview, as I was going through and kind of deleting incomplete notes for patients who had AA amyloidosis, a number of them had died. These are young people. It's really tragic. The other kind of thing I want to highlight is even outside of AA amyloidosis, our patients are much more likely to be homeless, as our own Yoshio Hall kind of highlighted in 2012 in C. Jason. Patients with homelessness often have about 6% have CKD 3 to 5, and they have higher rates of depression and higher rates of substance use. So they also kind of in this combination have a higher risk of death. So I think since I try to highlight that this issue of addiction really is at home in our department, I think that we should be kind of armed with a general knowledge of addiction medicine. So just kind of briefly defining, I don't want to go through the DSM-5 definition of opioid use disorder, but I think it's really important to highlight a couple factors. So one, opioid use disorder is treatable and it's relapsing. It's a chronic illness. And in the DSM-5, there's some really pertinent symptoms that are important to us as nephrologists. So one is a lot of time has to be spent in obtaining the opioid. And then there's continued use despite completely aberrant social and interpersonal problems. So these are completely destabilizing, and that destabilization defines use disorder. There's also has to be market withdrawal symptoms. So opioid withdrawal is incredibly important for our patients, and it's the primary motivator for continued use of opioids. So around 56% of patients reported avoiding withdrawal symptoms was a primary motivator for their continued use, and it's the most cited reason that patients who are prescribed oral opioids transition to heroin. Opioid withdrawal kind of in the most commonly used opioids illicitly will have withdrawal symptoms within 12 hours. Those symptoms include, you know, irritability, sweating, kind of, you know, piloerection or goosebumps, and then diarrhea and cramps. But really, it's this irritability, this restlessness, this internal tension that kind of defines the withdrawal experience. So the cycle of addiction is one of binge intoxication that transitions into withdrawal, and then that transition into a preoccupation anticipation. In this kind of cycle, this continued kind of compulsion, it creates kind of changes within the brain, neuroplastic changes in the brain that emphasizes and extends their amygdala, and it reduces kind of prefrontal systems and creates loss of control. Essentially, they are having this emergence of a negative emotional state that they have to suppress with use. So as we kind of outline recovery is going to look different for each patient. So I kind of want to frame recovery as not like an all or nothing, and there's different phases and stages, and we'll find our patients where they are and help them kind of find their own stage of recovery. So I'll go into this a little more detail, but I really want to focus today on transition, so finding motivation, stabilization, and then this early recovery phase. So our physician-centered goals for our patients often tend to be stopping opioid use, hemodialysis compliance, taking their medications. But when you are in the throes of addiction, often your goals are a lot simpler. They're survival goals. And so I really kind of encourage, whenever we're dealing with a patient who is kind of destabilized from their opioid addiction, ask them what their goals are. And through addressing their own goals, we can build trust and stability and kind of achieve overall health and eventually down the road recovery. So some of the examples of that might be, a patient might say, I'm really sick of coming to the hospital with infections. So we might have then the opportunity, if their goal is to not stop using, we can say, well, maybe we can try a different mode of administration. Maybe we can try using a needle exchange program. Maybe their goal is to decrease their opioid use. And that's kind of a stepping place where you can engage them in the path of recovery. And let's be honest, a lot of our patients just want housing stability, just want enough food to be comfortable and live. And so socioeconomic problems often are kind of like that bottom kind of hierarchy of needs that we have to address if we're going to build a path to stability and recovery. So as patients start to recover, there's an emergence of kind of two identities. One is that of continued life with opioid use disorder, and then one of survivorship. So I kind of want to highlight just there's two different mindsets as patients recover. And even in recovery, we have to treat each patient as an individual. So someone who might still have their identity of use, even in recovery, treatment with medication-assisted therapy, such as methadone and buprenorphine, will be important to continue for life. And this framework of still kind of having an identity of addiction helps them create constant vigilance. So they're constantly guarding themselves against relapse. And some patients have identified why they used. They've addressed their underlying cause, and they feel totally detached, and they don't feel at risk for using again. So for patients like that, de-escalation of medication-assisted treatment, these kind of changes can be made for them. Just want to highlight some patient experience. So patients, these are some quotes I found in a couple of journals. So you don't get high after a while, you just need it so you're not sick. And then people say when you get sick for Percocet, you're so sick, you don't care. You just want the sickness to be gone. And people also express kind of not really getting high anymore, just purely seeking the drug to maintain health and stay well. So each addiction has its own treatment, optimal treatment. And for opioid use disorder, we're kind of in this fortunate place where we have very effective medication-assisted treatment. Something like amphetamine use disorder, we don't have as good treatment. And so we often rely on psychotherapy. So there's two main treatment options. One is methadone and one is buprenorphine. I don't want to go into too much detail, but methadone is a full agonist, mu agonist with a very long half-life. And then buprenorphine is a partial agonist and has very high affinity, so it will knock off any of the full agonist that's bound to the mu receptor. Methadone, because it's a full agonist, can be associated with respiratory depression and euphoria. Both of them are metabolized through the liver, and methadone has a marked QT prolongation. Essentially, all patients after a while, after months of use, will have QT prolongation. Kind of thinking about its interactions with different immunosuppressions. So cyclosporin actually increases methadone levels, and then neither have any interactions with tacrolimus, and buprenorphine has no interactions with immunosuppressions. Buprenorphine is nice because it has a ceiling effect. So even at very, very high IV doses, you'll have very limited respiratory depression. So there's very low risk of overdosing on buprenorphine. Just kind of from an ESKD standpoint, neither are metabolized by the kidney. So both are safe to give in ESKD and no dose adjustments needed. And neither of them are dialyzed. So there's excellent evidence for these medications. They increase treatment retention. They are associated with opioid cessation, about 44% reduction in continued opioid use. They are life-saving medications, a hazard ratio of 3.24 mortality, and I believe the number needed to treat around 2. It's single-digit number needed to treat for mortality. These are life-saving medications. And then also they're associated with decreased infection risks, and there's a significant reduction in such as hepatitis C. So who can prescribe these drugs? So methadone is burdened by federal limitations, federal laws that require a specific license to be held if you're going to prescribe it for opioid addiction. Anyone can prescribe it for pain, but for opioid addiction, it needs to be a specific license. And it can only be dispensed in 3-day supplies. You have to go to a methadone clinic. Buprenorphine, since August of 2023, after Biden signed the Consolidated Appropriations Act, is totally open for anyone to prescribe who has a DEA license, of course, with no restrictions. So I guess the question is, what is our role in prescribing these? I had the benefit of as a hospital last year helping our hospital kind of come up with a buprenorphine team, and I've been part of inductions of buprenorphine, and it can be a little complicated, and there's also not a lot of consensus across the addiction community on what is the best way to dose buprenorphine and do someone on buprenorphine. For example, my old hospital favored a microinduction that takes weeks, whereas other hospitals will do a macroinduction where they're giving very high doses and getting people on buprenorphine in 1 to 2 days. Other hospitals will do a kind of standard induction that, in my experience, is associated with precipitated withdrawal. And so there's a little bit of complexity if we're going to start patients. But I believe if someone is stable on buprenorphine, it's something that, as someone who sees patients often in dialysis centers, who has great relationships with patients, I think we should feel confident kind of helping them. And if they need medications, it also can be, there's been conversations about getting methadone in dialysis centers. And I think these federal laws really kind of are troublesome. And since buprenorphine is much less restricted, there's an opportunity to maybe include that in dialysis centers. So if we're not the ones prescribing these, how do we get patients on these medications? So there's a UW addiction medicine clinic that has walk-in spots across from Harborview at the Patricia Still building. There's also a very wide and excellent, King County does a great job with this. There's a recovery helpline where you can go and search for walk-in addiction clinics. And just searching in Seattle, this is all of the, I mean, I found a ton of clinics, a lot of them kind of in the downtown area. There's also a telephone number you can call and get a buprenorphine prescription. So as we kind of face kidney disease and factor in opioid addiction and kidney disease, I put this here because I think that there's this all-encompassing binge withdrawal preoccupation anticipation really kind of mirrors the dialysis experience. And going to dialysis, recovering from dialysis, the fatigue after dialysis, and then this maybe small bit of time where you get to have this self-directed experience, this self-care experience. And when you put them on top of each other, you can't do both. It's just impossible. I mean, both of them are totally remove you from a normal life. So I think that I kind of want to go through a kind of biopsychosocial assessment of a patient who might have ESKD and addiction. But these are some kind of considerations, some kind of high level points. So your time for self-care and kind of like self-growth it doesn't exist. You can't do both. I believe you can't actively use and be destabilized by your addiction and manage your diet and ESKD. Really, the primary concern for our patients is avoiding withdrawal symptoms. That's going to take over survival. It's the most important thing. And then, having constant illness, you can't control your chronic disease. That creates fear. Our patients know, and that then leads to further, kind of investment in these pathologic coping strategies. And then, therapeutic alliances with their nephrologist, multidisciplinary team is really important for better outcomes. So kind of looking at a biologic assessment, these withdrawal symptoms, I kind of want to like dive into it a little more, because if they're happening within 12 hours, how are we expecting our patients to go to dialysis every other day and not be using before and maybe forgetting to go to dialysis? If we don't have a way to manage withdrawal symptoms within a dialysis center, then we're going to have a hard time having our patients be compliant. Then kind of the dialysis experience, the pain, the cramping that might mimic some withdrawal symptoms, and have patients kind of go and say, I need to go back and use more because I'm having these adverse symptoms that might be from dialysis. Infectious complications are so destabilizing, really contribute to the illness of our patients, and dialysis access only increases those. And then, because you can't do both, our patients are very often hospitalized. So kind of, as I was alluding to, had the luxury of kind of being part of a buprenorphine team, or helping create a buprenorphine team. So the basis for inpatient induction of buprenorphine is really outlined by this 2014 JAMA article, where it showed that buprenorphine initiation for hospitalized patients was successful in lowering illicit opioid use, and they had kind of less opioid use during follow-up periods. So, so what they would do is they started people on buprenorphine, linked them to care within a week. So on discharge, they had a follow-up appointment, and then they kind of were able to engage in outpatient treatment. There's also I really think it's quite weak evidence, but there is some evidence that emergency department initiation of buprenorphine is associated with increased buprenorphine prescriptions at 30 days. But regardless, I think the inpatient period presents itself an opportunity for us to kind of capture our patients and hopefully stabilize them if we're kind of thoughtful and honestly aggressive in our treatment. At the New York Health and Hospital, at Harlem Hospitals, they had a pretty unique approach. So they did substance use counseling. If someone said that they wanted to stop using, they would start them on inpatient, very, very high doses of buprenorphine. And then once they were stabilized, they gave them a long-acting injectable of Sublocade, which is long-acting buprenorphine. It covers you for 30 days, where you don't need to take any medications and you have the buprenorphine on board, essentially eliminating the decision to take buprenorphine for that first very unstable first 30 days of their recovery. They had good success, and I kind of admire this process, even though it's not studied and it's just one hospital doing it. So other kind of psychiatric assessments. So psychiatric comorbidities are really important. Patients often have trauma as the reason why they use. So if we're not kind of probing into and addressing trauma, then they're not going to have that stability to stop use. I think it's really important to ask our patients why they are using. And if we're not understanding kind of their day-to-day and their decision-making process, then we're going to have a hard time kind of working to underdo that process. So finding motivations for use and helping identify different coping strategies. So often patients will use for coping, and if we don't kind of replace it with something else, then we're going to have a hard time. And then social, and especially as we're kind of transitioning to talking about maybe transplanting, these social networks that patients have are so anchoring in their addiction. And if they don't have healthy social kind of circles, they're going to have a very hard time eliminating themselves from addiction. So, I guess you could even think about yourself and what you do with your friends. And if you have a group of friends that maybe you always go out for a drink and then you no longer can drink, and then you're like, what do I do? So I think that feels very real to us, and it's kind of a universal human experience. The other thing is there's a lot of stigmatization that comes with addiction, and patients feel like they can't be honest with providers, and they can't kind of maybe they deserve this state in life because of the society telling them that they deserve that state in life. There's stigmatization that's present. And then, of course, our extreme poverty that's only getting worse is really very hard to. You can't manage your CKD and also addiction and also be extremely, extremely poor and struggling to survive. So I want to give kind of an action, please. Give us a framework to how can we help our patients. So in the transition phase, someone who is extremely unstable, maybe patients that are inpatient at Harborview, kind of focusing on harm reduction, talking to our patients about their goals, what do they hope for their own future, and engaging them in building a trusting relationship that we can then build on in the future. And then just creating open conversations about their substance use, kind of trying to eliminate that stigma, help them kind of trust and express themselves, and then making sure we're partnering with them with their withdrawal symptoms. Then as they maybe work towards recovery, getting them on medication-assisted treatment, methadone, buprenorphine, establishing a network of mental health providers, ensuring they're compliant with dialysis, and then really working on building that support network is going to be very important to build then on further recovery. And as they are entering early recovery and they're kind of a couple months abstinent from use, kind of helping them identify different coping strategies, exploring relationships with their addictions and why they're using, how we can avoid relapses, and then kind of continued investment and continuing to build out that social network. And if they're comfortable, including them in their care. So, then, if we're able to build a path for recovery, how, when and how is transplant appropriate for these patients? So I kind of want to reflect a little bit on mortality. And I believe that reducing mortality is one of the main motivators for why we do transplantation. And, in the first year of starting dialysis, high utilization of opioid is associated with a 1.8 hazard ratio for mortality in a time already associated with a 30% mortality rate for the patients. In addition, these patients tend to be very young. And I think if our primary goal is to help prolong life, then this is a very high-risk population that deserves a proactive approach. So I guess, unfortunately, in the way we interact with addiction in transplantation is often in our donor pool. So there was about roughly a 300% increase from 2010 to 2016 in kidney donors who had drug overdose. And it represented about 13% of the donor pool, adult donor pool. In addition, donor organs, they tend to be healthier. They're good organs. They have a low KDPI, and they are much less likely to have kind of comorbidities. But they do have a kind of a similar 5-year graft survival. So at UW, kind of how we approach substance use is we have patients kind of review and consign a consent. The consent really focuses on all types of substances, nicotine and marijuana being a kind of primary role in that kind of counseling. And really, we're only testing for marijuana and nicotine in our patients. I don't know if we're actually routinely using kind of broad urine drug screenings for opioids, or even if patients have a history of opioid use. I'm not sure. So I think I wonder a little bit if we're not testing because we're not even really thinking these patients are going to get to us. I'm not sure. But I do think that there's a really practical kind of approach to a second chance, and I think the clarity of this this kind of approach is really useful. So what does KDIGO say? So KDIGO, and I'll kind of read this word for word: an active psychiatric or ongoing substance use disorder that affects decision making or puts the candidate at a level of post-transplant risk that is higher than acceptable to the transplant program. So very, very vague language. Kind of saying that active substance use is, risky and probably shouldn't be transplanted. They kind of go into further and say substance use has been found to be an independent risk factor for non-adherence and graft failure, but they acknowledge that this is very weak evidence. So digging into the evidence for opioid use, there's 2 studies that they cite, primary literature. Both of them are a review of kind of medical records for patients who filled opioid prescriptions. So these are prescribed opioids. They split patients into 4 quadrants, with level 4 being an incredible amount of opioids, a credible amount of oxycodone. It's 23 morphine milligram equivalents per day per kilogram, which is around like 200 milligrams of oxycodone per day in a 70 kilogram person. And kind of interestingly, complications, they found that non-compliance was actually not much of a factor. They were comparable between groups. But maybe a little more striking, a second study with the same data, the same kind of quadrants of opioid use, found that patients in a Q3, the quadrant 3 and quadrant 4, that very high use, was associated with a higher mortality. All-cause graft loss was also higher. However, if you censor death, then they have an equal rate of relatively equal rate of graft failure. So it seems like that graft failure was mainly driven by deaths. I just want to kind of another reflection on language. So I think KDIGO, they don't have much evidence, so they're trying to be kind of broad. But I think that broadness and the lack of clarity can cause harm for our patients. So one referring nephrologist may interpret these KDIGO guidelines to say, if my patient has used substance, they don't get to go for transplant. It also allows vague guidelines around room for physicians' personal biases. Maybe someone who has substance use is not as deserving of an organ as someone without substance use. It aligns with socioeconomic and racial factors, leaving rooms for compounding bias. And then affluence and wealth certainly plays a role in saying what someone's social worth is. And a vague guideline might place more social worth on someone who has affluence and does not use substances. I also think that there's room for false equivalencies. So maybe a little bit of my opinion, but I'm not sure if tobacco, marijuana, or alcohol have the same risk if we're prioritizing compliance as something like opioids. So kind of when we're seeing our patients in clinic, identifying those who are likely to recover or have the lowest risk of relapse can help us identify, hey, who can we really work on? Who might be able to make it through to transplant? And so amount and duration, so more than a gram of heroin and more than 3 years of use had a really kind of poor relapse prediction. greater than 2 prior attempts at detox. And then actually, this is non-modifiable, but like a parental or first-degree relative with opioid use, unfortunately, was pretty predictive that they are going to have a hard time recovering. There's a very practical kind of screening tool that I found in a JAMA Psychiatry article in 2023 that actually just looking after you say, I'm going to be abstinent, doing urine drug screens every week. And if you don't see opioids in the first 3 weeks, then you have actually a fairly good chance of sustaining without relapse. And it was about 20% of the patients had relapse, which in addiction is pretty good. So as we kind of highlighted, there's not much data for opioid use in kidney transplantation. So we have to kind of rely on the liver transplantation. So how the liver kind of side does things is if patients have acute alcoholic hepatitis, then they do not care about your substance use. And maybe that's a little brass to say, but they are fine to transplant you because your survival is really poor. And they found that in this New England Journal study, only 3 patients actually returned to alcohol use. But they do recommend a 6 months of abstinence before transplantation. So they also have a data set of patients who had used opioids and on methadone maintenance. And out of 36 patients, they had pretty comparable survival rates, and only 4 patients relapsed into opioid use. That being said, all patients had good social support in 6 months of illicit abstinence. And then this was another study kind of looking at methadone, and they were associated with a worse outcome, worse survival. So I'll just finish up. I know I'm kind of going over on time. I'm sorry. So using this biopsychosocial kind of platform, having dialysis compliance, making sure you're stable on medication-assisted therapy, making sure they're engaged in substance use recovery programs, and have a psychiatrist, and they're working on kind of the underlying reasons for use, and then making sure they have good social outcomes and a really strong support system is going to be the framework and the treatment plan for how we acquire abstinence for 3 to 6 months. And it's my suggestion and my kind of thought that abstinence for 3 to 6 months, depending on your risk, should be good enough to go forward with transplant. So I want to just kind of close with Iris had sent me this card that she had received from a patient with AA amyloidosis that we have transplanted, and it's basically it's so like heart melting, So I think I just have this quote from Jenny Odell, who's she's an artist and author in Oakland, and I think as we struggle with this problem that's very real to us, we have to hold in our minds this contemplation for a future of health and hope for our patients, and acknowledging that holding for this idea of holding a future that doesn't exist yet in our minds can be really sad. And but we have to do it in order to have our patients' health in their best interest. So anyway, I want to thank my mentor Laura Maeda. I want to thank the transplant team. I want to thank Iris and Chris for kind of helping mentor me through this talk, and Tom Soprano, a soprano who was very, very helpful and very kind to talk with me on the phone about this. And then also conversations with Fanola really were helpful for this. So thank you all, and I'll close for questions, or maybe there's not time.
Thank you, Josh. That was a really fantastic talk and really enlightening in a lot of ways. And I think, there's much work to be done, both obviously in the transplant sphere as it relates to opioid use and beyond. So thank you.